Western Regional Training Center in Health Services Research, or WRTC, that is the sponsor for this seminar. And we are doing this jointly with our WRTC sister site at the University of Regina. And the WRTC is a training program for graduate students in applied health services research. And so we meet together, the students who are a part of the program, every couple of weeks, but we open our seminars up to everyone, and we're delighted that there's such a variety of individuals who have come today. I'm going to turn the floor over to one of the trainees in our WRTC program, Juan Nicolas Pina-Sanchez, who's going to be moderating this session.
Good afternoon here in Saskatchewan. Good afternoon in Regina. As Dr. Lix mentioned, I'm Juan Nicolas Peña-Sanchez. I'm a WRTC student, and I'm doing my PhD at the School of Public Health here in the University of Saskatchewan. I have the honor to today introduce Dr. Nazmi Sari. I had the opportunity to have some conversation with him, and I'm sure we are going to enjoy this seminar. Dr. Nazmi Sari is an associate professor in the Department of Economics at the University of Saskatchewan. He received his PhD in economics from the Boston University in 2001, and before joining the University of Saskatchewan in 2004, he has taught at the Florida International University in USA. Dr. Sari is a health economist with a specific research interest in quality and efficiency issues in hospital markets, provider reimbursement and healthcare financing reforms, and economics of smoking and physical activity. His research published in Economics, Health Policy, and Medical Science Journal, and has been supported by several funding agencies, including the CIHR and the Saskatchewan Health Research Fund, as well the U.S. Center for Medicare and Medicaid Services. Besides, Dr. Sari has taught graduate and graduate courses in health economic, microeconomics, and quantitative. In addition to his appointment at the university, he is research faculty at the Saskatchewan Population Health and Evaluation Research Unit. Dr. Sari is also a recipient of the first prize of young researchers in health economics paper competition awarded by the International Health Economic Association. So today's presentation is about physician activity and length of hospital stays. So please join me to welcome Dr. Nazmi Sari. Thank you for being here.
Thank you for all of you, and thank you for inviting me. And I'm hoping that the Regina also hears me well. If not, then I expect somebody from Regina will let us know. And today my talk is about the physical activity and length of stays. And at the second part of this talk, I intend to talk about whether or not the physical activity and hospital stays are associated with differently for those people with illnesses. Let me just give you some introduction or background about this issue before I go into the details around the physical activity and length of stay. If you just look at some statistics from several statistics institutes, you will see that physical inactivity is in fact quite high in many countries, especially in developed countries. You can see figures such as, if you look at the Canadian data, you will see that the inactivity is about 56% of the population, according to 2001 figures. And if you look at the data right now, it's not going to be much different. And if you consider those people who are not at the level that can be considered totally physically active, that will be about 2/3 of the population for those people who are 20 years and older. And there are, enough literature to convince us that there is significant implications of physical activity on health and healthcare. And one of the reports that I cite here mentions that physical activity, especially inactivity, can account for about 1.9 million premature deaths, or can associate it with 10 to 16% of breast cancer, colon cancers, or diabetes, or about 22% of heart disease can be also correlated with physical activity. So what I would like to do today, before I go into detail, so I'll just let you know what I'm doing, and then what I get one of those main results, and then I will go through these each of those processes throughout my talk. So, simple, the basic purpose of this talk is to estimate the effects of physical activity on length of stays. The question is whether or not it's common knowledge that, almost common knowledge, I should say, that the physical activity has some implications for healthcare utilization. But if you look at the literature, including the economics literature, there is not a lot of evidence showing the exact nature of the association. And so this is going to be one of the additional maybe study to few of other studies in the literature, and estimating the impact of physical activity specifically for hospital services. And then at the next level, I would like to look at the issue by different sex groups, female and male, and by different chronic conditions. This is the area, especially by gender and chronic conditions, I haven't seen, to my knowledge at least, I haven't seen any paper focusing specifically on chronic conditions, people with chronic conditions versus the implications of physical activity on hospital stay. Data comes from the National Population Health Survey, which I will tell you in a second, a little bit more about it. That will be actually a little bit longer than a second though. And this is a panel data, Canadian data, and covers about 16 years of period, starting from 1994, ends in 2008. Since it's a panel data, you can understand that this is following the same number of same people over time. And one of the main results of this paper is that physical activity, yes, decreases hospital stays in general, but if you look at for specific population groups, it's not the same for everyone. And it's effective, interestingly, for female, but not so for male. That's the main results of the paper. So before I go into the details about the paper, let me tell you some definitions for physical activity, which you already hear about. I say active, inactive, and moderately active. So these definitions are not my definition. This is the definition primarily used in the literature, and also adopted by the Statistics Canada. And for those people who will be considered inactive, will be the people who are walking, for instance, 30 minutes a day, or less than 30 minutes. It should be every day. And the speed gotta be about 4 kilometers in an hour. So it's a very fairly slow walk. And if somebody chooses to run, that will be usual 3 times a week, and about 23 minutes in every session, and that will be with a speed of 8.5 kilometers. And the active people will be the one who are walking more than 1 hour, at least 1 hour or more, again 4 kilometers an hour. And for those who choose to do more intense exercise, that will be maybe running for 3 times a week, and 45 minutes in every session. And moderately active will be those people who are in between. And again, if you look at the literature, you will see that why being physically active will make sense. And I'll see you a couple of more evidence starting from this list, and then I'll show you some other evidence coming from one of the papers published in New England Journal of Medicine. And these are the ways that the physical activity could be associated with different type of chronic illnesses. And then this is one of the reasons why I would like to specifically look at the impact of physical activity for those people with some chronic conditions. And if you look at this slide, where what we see on this slide is the white ones. The dark figures shows those people who are physically active, and the white bars shows those people who are inactive, and the one in between is going to be moderately active people. And on the vertical axis, you see the relative risk of death. And everything compared, those two groups, inactive person versus and moderately active people, compare with the active people in terms of risk of dying. And compared to, and in each of those, of course, different population groups. If you look at the first group of bars, which is the case for people with hypertension, and you can see that those people who are inactive is about 70%, according to that lower confidence interval, 70% more likely to die. given throughout this process, throughout the period of the study. And then you can see that in each of those disease or behavioral groups, you can see that always the physically active people, physically inactive people have higher rate of dying than the active people. And if you look at the second group, where that's for the COPD, the confidence interval will get closer to the between the active versus the inactive people get closer to the each other. And this is another slide which tells you a little bit different story. The story over here is on the horizontal axis. We have the people in different quantile of exercise capacity. And you can read this exercise capacity being more active. And if you go on towards the other side of the graph, from 1 to 5, 5 will be the group of people who are very, very active. 1 will be the cases where people are inactive. So this is comparing, if you compare normal subjects, that's the bars with dark color, you can see that the relative risk of that decreases as people become more and more active. And you can say the same thing for those people who has cardiovascular disease. And if you look at to the last two columns, going from 4 to 5, you see that those improvement for those people who are normal is less than compared to those people who are with cardiovascular disease. So this is another way of showing you that exercise and health and healthcare potentially has some correlation. So if you look at the literature, specifically looking at healthcare utilization and exercise, and I cite here only 3 papers. This doesn't mean that there are only 3 papers. There's a lot of papers. If you look at the studies coming from the occupational health promotion or occupational health promotion studies. So, but if you look at the rest of the literature, you're gonna more or less see the same picture. Where first paper is looking those people who are Bank of America retirees with a small sample, and then they show that 100 minutes more exercise every week, which may actually create about $214 to $660 saving per person per year. And other studies are giving you this more or less the same picture, where the second study, that's a study from University of Kentucky, where they do offer a worksite wellness program, and what they do, they compare those people who are part of the worksite fitness program versus not, and they conclude that those people who are part of the wellness fitness program will actually have about 30 to 46%. The other group will have 30 to 46% higher healthcare costs, those people who are not part of the wellness program. Again, this is another evidence comes from the literature, but if you look at all of those studies, these studies, and as well as other studies which is not shown here, is coming from the very specific population group, Bank of America retirees, or in a university context, or 517 Texaco employees. This is an evidence, but it's not really clear whether or not we will be able to make some generalization based on those specific population groups. And if you look at the other literature, which is the literature primarily drawn from economics literature, there's not a lot of papers there. And before I start working on this area, I will be able to identify about 3 papers, and to my knowledge, there are not many other papers available in the literature specifically looking at this issue, physical activity and healthcare utilization. And first 2 papers are paper from US, and those researchers, although the first author is a different person, it's the same group of people. The first one is a paper in the American Journal of Public Health, and the second one is a book. And the third paper is a paper from, I think, Finland. And the other papers, which are the ones I wrote, they are all Canadian studies. And these studies primarily coming from the cross-sectional data, though. It's a very general, generalizable population representative sample, but they come from the cross-sectional data. And their more or less common point is, yes, physical activity will be effective in reducing the healthcare utilization, And the range of that saving will be in the range of 20 to 38% higher utilization of hospital stays for those people who are inactive compared to others. And in terms of the physician visits, higher utilization by those people who are inactive will be in the range of 5 to 28%, coming from all over those studies. But again, if you look at these studies, I haven't seen none of them actually specifically primarily focus on the different sex group or are not looking at the people with chronic conditions. So that's going to be one of the contribution of this current study that I'm presenting today. But before I go to the data and the empirical part of the paper, let me just give you some economics framework for us to understand the potential meaning of those results that I'm about to present here. So in general, what we use in economics, if this is about people, consumers are making choices, we use theory called consumer theory, where the consumers make some choices among different set of goods and services. Here in this model, which is a model used by others, I could say about 40 years, slightly different from the general consumer theory models. And the difference here is we have an individual consume some consumption goods and services, derives utility from those consumption goods and services. At the same time, there are other goods, such as medical care. Not necessarily individual will derive direct utility from going to the doctor or getting a surgery. But those are going to provide indirect utility, indirect satisfaction to the consumer through the health production. In other words, you consume healthcare services in order to improve your health. Improving your health is the reason why you actually have any interest in consuming those services. And if there is no channel, there's no indirect channel through health production, that's the equation written in the bottom of that slide, then there might not be any reason why the individual will have an interest in consuming healthcare services. So simply, health matters, healthcare not necessarily matters in this model. So you consume medical care just because you want to restore or improve your health, otherwise you have no reason to increase the consumption of medical care. So if we take this model and then if we just apply the way that we apply in economics, which is a utility maximization problem, every individual in the society, based on consumer theory, given the constraint, prices and their budget constraint, they try to maximize the satisfaction by choosing the optimum allocation of those, optimum number of goods and services. Here, from now on, when you see E stands for exercise, and H stands for health, and M stands for medical care. So you're going to see M and E a lot of time throughout the talk. And Z will be the other goods and services, which is not really important for this context. So if you take, if you do that optimization problem, that optimization problem is going to give you, very straightforward, simple equation, where you have two terms here. One term is the marginal benefit of medical care per dollar, and the second term here is the marginal benefit of exercise per dollar. And when the individual is trying to allocate the resources between medical care and exercise, all they are trying to make sure that the additional dollar is going to bring comparable benefit, additional benefit from exercise versus the medical care side. So that's the idea. And a couple of other things here. If you look at the second term is all about the exercise. And exercise not necessarily is going to have only direct benefit, which will be the second term in the top part of the second term, UE. That's the marginal impact, marginal effect, or marginal satisfaction someone will get from exercise. So that will be direct benefit, direct satisfaction you get from being active. However, the first term will be the indirect effect of exercise on people's satisfaction because of the exercise effect on health. So you can imagine in this model that if, in fact, we have someone who hates exercise, which means that the U of E, UE, that last term is going to be negative. So you hate it, but still it's likely that this individual may exercise. And the reason is because the health production, the impact of health production of exercise could be quite high. So imagine a chronically ill patient who gets a lot of advice from the patient, from the physician, and convinced that exercising is a good thing. because of this impact on health production. And this individual may hate to exercise, but may choose to participate. So that's the intuition here. And so as long as the second term, the numerator of the second term is positive, you're going to see that this individual will participate to exercise. And so those two effects is important. But how the people are going to substitute exercise for medical care is not really clear. I don't want to spend much time on this. You can just take my word that this is what you see here is correct. And the sign of this cross price effect, or you can work on it if you want to, and give me the results, and hopefully you get the same result and I feel comfortable, otherwise I'll break mine. But there's a lot of term here, and so I work on different scenarios. Then there's only one clear scenario I can tell you where this is going to be positive, which means that if it's positive, then exercise and medical care are substitutable. Hopefully exercise is going to decrease the demand for hospital stays. So that's where I'm trying to go from here. So I want to show whether or not this term could be positive. In other words, when I estimate the model using the quantity of physical activity on the right-hand side, whether or not the impact is negative. So these are substitutable products. Not necessarily always it's substitutable. Depends on the individual choices, right? Depends on how exercise will be effective in the production of health. So those are the issues where we may not get a positive sign over here. So it's not going to be surprising not to see some positive results, perhaps for the male. That's why we don't see that. And so the sign of this cross price effect is ambiguous. It could be 0, it could be negative or positive. That's why it makes a lot of sense that we have to work with the data. So we go to the data and we look at which sort of hypothesis can be tested and supported by the data. So that's where the second part of the talk is all about. Okay, what I am going to present from now on is all about those empirical part of the paper. And the paper is going to depend on the panel data, National Population Health Survey. This health survey started in 1994 and conducted every second year and available for about 8 cycles. It covers 16 years of these same individuals, but for every other 2 years. And it's a representative population, representative for the Canadian population in 1994, of course, not as of today. And in terms of what we have in this database, we have a lot of information about the health determinants, socioeconomic background, demographic characteristics, health status, healthcare utilization. More importantly, there is a lot of information about physical activity. That's the important part and why this data become quite useful. And from now, sometimes I will show you some sort of association between physical activity and hospital stay using a representative sample as late as today. So that's going to be coming from the cross-sectional data, Canadian Community Health Survey. That's some of these sort of descriptive statistics will be based on the cross-sectional data, but the entire analysis based on the panel data. Again, so as I told you, there is a lot of physical activity measures used in this survey. And these are all about the total daily energy expenditure of from different leisure time physical activities. So it's important that these are the leisure time physical activity. But the good news is we have some other information about the non-leisure time physical activity too. I'll come to that in a second. And we do have questions, specific questions in this survey related to the type of the activities and the duration of the activities. So using those, all of those information, it's possible, and it's already done by the Statistics Canada in the database, that you will be able to estimate the total daily energy expenditure from all different type of physical activities. So we know the energy expenditure from the physical activities. And the way that they calculate this, based on this simple formula where D stands for the duration of the activity K. So there might be, big capital K number of activities individual J might have. So EJ is going to be total energy expenditure for individual J. And this individual might have 15 different activities, from soccer, walking to swimming and everything. And for each of those activities, DK will represent the time in hours of daily activity from each of those activities. And the GK is the energy expenditure from K in kilocalories per kilogram of body weights in an hour. And So this GK is calculated using the corresponding metabolic rate for activity K. If I give you some example, if it is 1 met, if the GK is 1, that will be approximately, this will be equivalent to 1 kilocalories per kilogram of body weight of the individual in an hour. And some example will be, if we are talking about someone who is 70 kilo and exercising at an exercise intensity of 3 mets for 1 hour, so that will be walking 4 kilometers in an hour, and that will be total of 216 kilocalories, or 3 kilocalories per kilogram of body weight. So, but in each of those estimations and every figure, you will see that the total energy expenditure is going to be in terms of kilocalories per kilogram of body weight, rather than the total. If I show you the total, it really depends on the body weight of the individual. So it's all, you know, comparable when it becomes kilocalories per kilogram of body weight in an hour. And these are some other examples if you would like to see, you know, so GK to be 2 mets, then you need about 40-minute walk for pleasure with a speed of, again, 4 kilometers in an hour. Or you could actually do it only for 15 minutes if you want to run, with a speed of 8 kilometers an hour, and so on and so forth. Okay. Some statistics coming from this National Population Health Survey. Over time, I do show you data up to 2006, although data for 2008 is also available. And I didn't have time to actually put that together. It requires some process in the research data center. You have to have the data ready there, and then it has to be approved by the data analyst for you to use those outside of the facility. Anyway, so the data for 2008 will be available. And then if you look at the first line over there, that's the total energy expenditure. And you see that in 1994, it starts from 1.75, and then it, you know, increases, sometimes increases and decreases, and so on and so forth. And the numbers are, in parentheses, are all standard deviation, and the rest of the numbers are the average of the corresponding variable. And then if you look at the second row, that's the change in energy expenditure, average change. And then, for instance, if you look at the second column, 1996, the change is not much, 0.01. So it's a very tiny change. And then after a while it changes, but sometimes it's up and down compared to the, you know, it's each of those compared to the earlier year, one earlier cycle. And then if you look at those people who actually increase their exercise, that's actually not bad. There's about 50% of the people in this sample who actually increase their exercise from one year to another. That's promising. And then if you look at for those people with any sort of participation, for those people who actually increase their physical activity, and then if you look at the change within that group, the change is actually even larger. It's quite high, about 1.3 to 1.4. So that will be about 30 minutes walk every day. That's not negligible. And so looking the hospital stay for the, again, same group of people, starting from 1994 all the way to 2006, and you can see that the proportion of those people who stay in the hospital ever in a year will range from 8% to 10%. 10% in 1994, and then it goes down to 8% and almost stable around 8%. And one note, of course, you probably guess it, what was going on here, why the people are being active over time. You can imagine that many people over time is going to die. And then those people who dies are the potentially the people who are inactive, and then that's why you get the higher, unfortunately. So don't get excited that there's a, you know, physical activity increase over time. That's not the case. We have the people who are inactive disappears from the sample. And you could have the same sort of actually picture here, perhaps, that the hospital stay, if you look at the first column, decreases. This doesn't mean that the population becomes healthy. Only remaining population becomes healthy. So you have those sick people who dies over time, and then you end up with the people who are relatively healthy and less user of services, potentially. That's potential explanation, not necessarily for sure. And then if you look at the last column where you will see the hospital stays, for those people who are any user at all, if they use positive number of, you know, services, then among those people, you know, the hospital stays is quite high. It's, for some reason, low in 2006 goes to 6 days, but for other years it's in the range of 8 to 9, even close to 10 days in a year. This is for those people who has any stay. Look at that 10% of the population, and if you look at the usage within that 10%, then you can see that the length of stay could be about 10 days. Okay, so here what I'm trying to do is, here I want to show you some data from the Canadian Community Health Survey based on 2007 data. This is the representative sample for 2007. And then, the data shows you correlation, simple correlation, I should say. Although it comes from this non-parametric kernel-based regressions, but what it is simply the weighted average, weighted correlation, or imagine a scatter plot, but we will be able to then, push it down, and then we'll be able to express that with a line. So maybe that will be the good intuitive explanation of what you are seeing here. And so what we have here is the physical activity on the horizontal axis. So as you go away from 0, which means that people are being more and more active, and on the vertical axis you have the number of hospital stays, length of stay, and you have a clear negative correlation here. That's a good news. That's what I want to see at the beginning for me to go any further. So I take that, good picture from this cross-sectional data that there is some negative correlation, and then I want to investigate what are the sources and whether or not this negative correlation will survive, will stay if in fact we control for other factors and if we use panel data. To do so, I want to estimate its model, where the left-hand side is a measure of hospital stay for individual J at time t, which will be estimated using a lot of right-hand side variable. The second term, E, JT, is the physical activity term. So that's my primary focus is there. But I have to, of course, control for other factors, individual level factors, XI, XJT. And the good thing about the panel data, if there are some time invariant individual characteristics, for instance, people are very motivated, that's why they are active, they are motivated, that's why they are healthy too, they do all sort of other stuff, and then they don't go to the hospital as much. That's not what we would like to identify. We want to make sure that we can get rid of those sort of impacts. So this panel data model will be able to capture that unobserved, even if it is unobserved characteristics. So that's the advantage of the panel data model. Okay, other than the physical activity variable, there are other factors that we have to be very careful in including this model. That X should include many other variables. One set of variable has to be non-leisure time physical activity. If physical activity good for health, if there is a potential that the physical activity will decrease the hospital stay, it is likely that when people are active during their non-leisure time, perhaps they may not be active during their leisure time. So there might be some sort of correlation if you actually do not include these information in the model, and then biking for leisure time or for work might have the same influence. Then you won't be able to capture that effect of the leisure time physical activity, or won't be able to get rid of the other potential impact through non-leisure time physical activity. So these are the variables which is available in data, which are all included in the model. There are other factors, which is, we are lucky that we have panel data. Earlier level of activity may influence individuals' hospital stay now. So we have this information there, and then it can be included in that. Obviously, people's health status, chronic illnesses, or injuries is going to be correlated with their hospital stay as well as their leisure time physical activity. So someone who is injured, less likely to be active and then more likely to be in the hospital. So that correlation is going to be potentially from injuries, not because of the inactivity. That's one reason why we want to make sure that these factors are also included there. And there could be other behavioral factors. If physical activity is one of them, perhaps smoking, BMI, obesity, or alcohol consumption could be other ways that is going to be correlated with people's tendency to be active. If someone is active, it's more less likely to be a smoker either. So these two effects may actually go together, and then they may lead to lower utilization of services and we don't know whether or not this is because of the smoking or physical activity. We want to make sure that those factors are also excluded. And there are, a lot of other factors such as age and marital status, income, education, employment status, home and household characteristics, place of residence, provinces. And there could be some time trend, which I will come to that. And then there might be some seasonal effects for level of activity. So those are the other information and which was available in data, so that can be, I will be able to control for those factors. Okay, from now on, in each of those regressions that I'm going to show you, all those variables that I show you are already included. And then I show you some, variables which I thought, more interesting to look at it. And of course, the physical activity is the most important one that we would like to look at it. And first two variables are about the physical activity now and physical activity 2 years ago in the previous cycle. Lag value versus now. And then the third variable over here is whether or not the individual die within 2 years. Since this is a panel data that we know the death of the individuals, so we will be able to identify whether or not the individual will die within 2 years. And then there's a strong literature out there that if the people are usually higher utilizer of the services within their last 2 years of life. That's why this variable was over there. And then it's likely that if people are about to die, they might be physically. I want to make sure that this is going to be taken care of. And then number of chronic conditions. The reason, of course, my next step is going to be look at the chronic conditions and physical activity together, and poor health, obesity, and number of injuries. Those were the most significant variables that I can see from these baseline estimates. At first, what I do, I just neglect the panel data nature of the data, and I use the simple OLS model as if this is a cross-sectional piece. And then I move to the fixed effect models. This is a panel data model where we will be able to control for those unobserved characteristics of the individual. And you can see that the impact of the physical activity, which is here shown, in natural logarithm, the reason is because of the taking care of the non-linearity. Not necessarily the impact is going to be linear. Potentially, if you are extremely active, additional activity is not going to decrease the hospital stay as much. So at the beginning, you get a lot of impact, but if you do it 15 hours of work, it's not going to give you any additional maybe effect, if there is any. So that's the reason why this is in log term. And you can see that baseline models tells us this simple, straightforward story that the physical activity is a good thing. If we are being active, we may actually decrease the number of stay in the hospital. And here, before I move to the next slide, just want to note that the sample that I use here for those people who are 12 years in 1994. So, in fact, the NPHS survey everyone, including the kids younger than 12 years old. But the questions for those physical activity variables are not available for those kids who are younger than 12 years old. And if you actually include all of them, suddenly you have someone else appears in the sample in, let's say, 2008, used to be, not even born, actually 1 year. In this case, it will be 16, sorry. Used to be not in the data in 1994, within that 12 years and older. So I want to make sure that I have a cohort that I can follow over from 1994 to 2008. So I picked it to 12 years and older people in 1994, and then I follow only that group over time, and then do not include the younger people in the sample. So that's one of the important. And if you look at the coefficient estimate, just keep in mind, if you can remember this number, it's minus 0.78, and then you will see that maybe this is too high. And if you look at the impact of the physical activity on hospital stay, and in terms of additional impact of physical activity on hospital stay, that's what I call marginal effect, you will see that the physical activity is going to decrease the hospital stay a lot at the beginning, but if you are extremely active, it's not going to do much. So if you look at the horizontal axis, look at where we see 2, 3. So 3 means this individual is walking 1 hour every day. Imagine that someone is walking 1 hour every day and then increases walking time by another hour. this additional 1 hour walk is not going to do as much. That's what the graph tells us. So at the beginning, if you are totally inactive, better to do some activity from 0 to 1, which means that increase your activity from 0 minute to 20 minutes walk every day. You get a lot of effect, but after that, there's not much going on here. If you look at this picture and then compare with the guidelines, Canadian guidelines, it's actually quite close. Their guidelines is, you have to be active on most of the days, 30 minutes and I think longer. They change the guidelines all the time, so I'm not sure what's the current one, but the current one is somewhat close to this definition, I think. 30 minutes and longer most of the days. So that might give you something in the range of 1 to 1.5. Okay. And so if you look at now, utilization of services and physical activity by female and male, again over time, you could see that at the top panel of this graph where you see the hospital stay, female stays for any year longer than male. So females are a higher user of hospital services. And if you look at the bottom graph, you will see that in each year, males are more active. Males are more active and females are higher utilizer of these services. So this will suggest that maybe perhaps we have to consider breaking this sample. Maybe this one story for both groups doesn't really hold. That's one thing, one observation. There are a couple of other points that I would like to emphasize before I move there. Again, one of them is last 2 years of life. That's why, which I already mentioned, that it is important to include whether or not the individuals are within their last 2 years of life because of the potential impact of that on utilization and activity. And then if you look at those people who survived versus those who died within 2 years and their hospital stays, surviving people, stable, and those people who will die has increased trend and then actually increased a lot towards that. There's clearly a difference in terms of utilization between those people who are about to die within 2 years or who survives. So that's one interesting feature. And then if you look at the physical activity, again, those people who are about to die stay the same in terms of their activity, but those who survives increases their activity over time. That's another reason why you want to make sure that you capture that dimension. And the second issue is the time trend. It's quite possible that there might be some change in practice style, and maybe there might be some movement towards more outpatient treatment, day surgeries, things like that. And there might be more emphasis on physically active lifestyle. I think this is really the case that we hear all the time, how and why physical activity is quite useful and that we have to be very active. And so this time trend hopefully will capture some of those effects. And there might be, who knows, maybe some seasonal effects that needs to be also taken. Those are also issues that is controlling this analysis. But I want to show you this time effect over time for female and male for hospital stays, and then I will show you for physical activity too. You can see that both groups decrease over time. So perhaps there is something going on here. Maybe there is a more move from inpatient to outpatient basis treatment. And then if you look at the level of activity over time, again, level of activity also increases over time for both groups. So it's really important that we actually capture the time trend, which is also capturing the analysis that I showed you. Okay, now I go to the next level and then I break the sample to those two groups, female and male. I do exactly the same thing. Nothing changes. All of those factors I mentioned included, time trend, seasonality, and socioeconomic characteristics and everything. What you see, if you look at the first estimate over there, impact of physical activity on hospital stay, female coefficient becomes 0.15. The joint coefficient was 0.07, so it actually increases almost twice, doubles. And then if you look at the male coefficient, it disappears, nothing going on there. And each time when you see those numbers in any table that I show you, those are the standard, these are the T statistics in the regressions. And then if you see any star next to a coefficient, that means that those are significant at 5% level. And if you see a star, which is not totally dark, maybe they are close to 5%. That's why I also made a note some of those ones. That's not, not in this table though. I'll tell you whenever I show you one of those tables. So here, the bottom line here is that the female, it seems that, are the ones who get positive effect of physical activity in terms of less utilization of services, hospital services, but that's not the case for male. Is there any way that these results could be not reliable? That was my next question to ask before I go to the chronic disease discussion. And then I can identify, at least I can argue that there might be some shortcomings of the results that I showed you. And one of the important things is, perhaps there are people who are with physical mobility, such as people who are in a wheelchair. And of course, it's more likely that these people will be inactive compared to the others. And then it's more likely that they will be higher users of healthcare. This effect has not been controlled in the previous regression that I showed. And if this is not controlled, then potentially you will overestimate the impact of physical activity on healthcare utilization. This was one of the important things that I have to consider. Again, before I show you the next set of slides, just remind you that this coefficient without that impact considered is 0.15, negative 0.15 for female. But if we go to the next one, that I refine the sample in order to make sure that I take care of that potential problem related to the people who are physically immobile, some physical difficulty. So I want to have a very clean sample now. What I want to do, I still want to have those 12 plus cohort in 1994, but I want to make sure that I don't want to get into any sort of difficulty or fuzziness around those people who are in physical immobility. There might be people at the beginning physically immobile. There might be people who might be immobile somewhere in between from 1994 through 2008. So I want to make sure that these people never ever appear in the data. So I get rid of all of those people. Now what I have is just those people who are always mobile, no physical mobility, never ever again, and they are again 12 years plus in 1994. So to do that, if I take that course, subsample, if you look at the coefficient of the female, which was 0.15, now it's 0.05. So it's a very, very actually, significant change. But, 1/3 of that coefficient. And that, suggests that, yes, that, sort of was an issue that potentially lead us to overestimate the impact of physical activity. And then you can see the same thing for the overall population in the first column. But if you look at, again, the last column, still, I don't have any good news for male. Maybe it's a good news, I don't know. You don't need to be active. That's the good news. Okay. And if you look at the number of chronic conditions, their number of chronic conditions is significant for both groups, and for pool group and for male. So, and once now I feel comfortable, relatively more comfortable about what I show you without this business related to chronic conditions. Now I want to take that analysis and then I want to work with the people with chronic conditions and all those stuff to show you whether or not these chronic conditions make sense, or physical activity has different effect for those people with chronic condition. Again, I go back to that Canadian Community Health Survey to get some sense about whether or not I should actually have to guess any sort of different trend between physical activity and hospital stay for those people who has some chronic condition, any chronic condition, versus rest of the population. So if you look at this graph again, that's simple correlation, one-to-one correlation, nothing but nothing more than that, based on this kernel regression again. The red line is the association between activity and hospital stay for those people without any chronic condition. So there is not a strong association there. If you look at the overall group, there is a negative association there. So perhaps it suggests that perhaps the people with chronic condition might have a different picture, different scenario, different story in terms of physical activity and chronic and hospital stays. Okay, so I introduced that effect now. What I do is I keep everything as before. What I introduce here is I introduce a interaction term, this third term over there, chronic condition. This means that people with any chronic condition interacted with energy expenditure, physical activity. And if you start from the first line again, first estimate for female, again the physical activity has more or less the close impact on hospital stay for anyone. And for those people who has chronic problems, there's an additional effect, which is about -0.07 decrease of hospital stays. Okay, and then we have the number of chronic conditions, and some of the other variables are shown here, as well as others are not shown in this picture, in this regression. And then what I want to do, I want to study this chronic condition things a little bit more than what I showed you, because these chronic conditions, the chronic condition that I showed you over there, may include food allergies too, as well as COPD, as well as cancer and other important or other chronic conditions where we expect higher utilization of healthcare services. So I look at the literature, and then I look at the data, and then I start with this 6 main chronic conditions. I separate these 6 main chronic conditions, and then I look at whether or not these 6 chronic conditions will be different than the rest of the population. So what I show you over here from 2007 data again, association between activity and hospital stay for those people with any of these 6 conditions, which is diabetes, high blood pressure, cancer, heart disease, COPD, and stroke, versus those people who has none of these conditions. Might have food allergies, but not any of these 6 conditions. And then again, I see that sort of the different scenario here. Physical activity and hospital stay is not strongly associated for those people who doesn't have any of these conditions, any of these 6 conditions, but there is a strong negative association there for those people who has any of these 6 conditions. And I look at these 6 conditions versus the rest of the population if I get something there. So what I do, rather than looking at any chronic conditions, I look at having any of those 6 conditions versus others. Here, if you look at the first coefficient, we get more or less the comparable coefficient for female, not for the male. There's never ever actually anything going on the last column, so you can just ignore it all the time. I do. And if you ask me why, I don't know. Okay. And if you look at the third line over there, again, you can see somewhat negative insignificant coefficient. I say somewhat because it's not really 5%, but it's probably about 6%, significant at 6% with that T ratio of 1.87. And there's also literature suggesting that the obesity is also another factor which needs to be taken included. And then I said, okay, let me actually include obesity as well as these 6 chronic conditions. Now I do 6 of those chronic conditions plus the obesity, as part of those people who has any of these 7 conditions now, and interact that with the, again, physical activity. Now, size of the coefficient is almost identical. And, 0.091, 0.091. It's identical, but we get more significant, little bit more significance here. So it's, passes the 5% line for sure. And if you look at the first coefficient for the female, again, it's the size of the coefficient. Yeah, almost identical. There's not much changes. Okay, before I conclude this talk, then I try to do a little bit more, and then I look at each of these cases, if I have any good news for you. And interestingly, when I look at each of those conditions, each of those 6 conditions, and interact them, each of them with physical activity, you can see that high blood pressure has somewhat, negative correlation, negative impact there. I say, yeah, it's very close. I mean, I think the benchmark number will be for T statistics 1.96, so it's 1.93. It's probably significant at 5.5%. I could probably, safely call it, yeah, that's significant too. And COPD doesn't seems to have much, impact in addition to impact for anyone else, right? The first question is the impact for anyone else, whether or not these individual has any chronic conditions, and the others is going to be on top of that. And those people with diabetes or heart disease or even stroke, it doesn't seem that there is much going on top of the general effect. But we do have some effect for the people who has cancer, obesity, and high blood pressure. Again, just for the female, for male either. And then if you take those results and then if you want to play with them, if you want to show again those marginal effects, what are the level of physical activity where we can actually get even larger share of larger decrease in hospital stay, you can see that if the physical activity level is about in the range of 1, which means that 20 minutes of walk every day, you get, moving from no activity to that level is going to decrease the hospital stay for, people without any conditions. That's the top one. And the others are if they do have those 3 conditions. And after that, the impact stays, constant. It doesn't really change as much. Okay. So these are some, I think I should say, preliminary conclusion. There are more work needs to be done on this, and there are more questions that needs to be answered. And in terms of the additional work, this 6th condition was, yes, it was based on the literature, but it was also somewhat arbitrary too. There are a couple of other conditions that I would like to look at. One of them is back problem, which I didn't actually. I was pretty much sure that people with any sort of food allergies not necessarily will be different than the others, which is something that can be checked in the data too. But the back problem could be the case where we might have some additional effect of activity for that subgroup of people, which is something that I would like to look at. So there are a couple of other other conditions that I want to look at it. So bottom line from here, that exercise seems to have some negative impact on hospital stays, decreases hospital stays. And we do have this consistent negative effect for females. For any type of the regression, in our results I have shown you, almost the impact is almost precisely the same. But if you look at the impact for the males, the impact is always insignificant, with or without, or even if you do not want to work under different type of subsamples, without any of those restrictions, always you get insignificant effect for males. And then when we look at the differential effect by chronic conditions, we do have that negative and consistent association for females, not necessarily for males. Before I conclude, I have to mention that this research based on the Statistics Canada data set. And this is my view, that's not their view for sure. And it's all partially funded by the University of Saskatchewan Tri-Council Research Funding. That's all for today. Thank you very much.
Thank you, Dr. Sari.
Yeah.
Now we are going to proceed to for a question session. So let's start first in Regina. Do you have any question over there?
Hi, this is Li Hui Zhang from Regina. I have a question about the previous physical activity and hospital stays. I noticed that in your results, the lagged physical activity wasn't significantly related to current period hospital stay. So the implication of that might be, if I exercise now, then it's not going to affect my hospital stay 2 years from now. I'm just wondering if you could explain that, and if it's, if it might be interesting to look at the physical activity, say, in a longer period of time. Say if I, starting from 12 years old, 10 years later, 22 years old, looking at the hospital stay at 22, and look at the impact of physical activity over the past 10 years.
Thank you. Thank you. I assume that you hear me. Yes. Okay, that's a good question. And then this is actually the second time I got the same question, and then my answer didn't improve much from the last one either. And I think if I rephrase the question, I should rephrase it the way as follows. If we actually invest now in terms of more and more physical activity, whether or not this investment will stay with us, whether we will stay healthy. If the answer is yes, then yes, it's going to then have some return today too. If not, then it's not going to. And this is not an area that I can speculate, but I can maybe suggest that physical activity, if it's going to, let's say, help you build muscle, which make you healthy, not necessarily you will be able to keep these muscles forever if you do not keep, being active. And 2 years might be long enough for you to actually lose all of those potential impact. That's so. It might, and another important issue over here is that this is the hospital stays. This is very significant health problems. So we're not talking about the minor health problems. We're talking about the major health problems. And I'm not sure whether or not being active about 10 years ago or 2 years ago is going to decrease significantly your probability of having one of those diseases and then make you stay shorter. But it's a good question, and when I try to understand the reasoning, the potential reason, and then look at the literature, I come across of one study suggesting that the impact of activity on health may stay about up to 6 months. And then anything longer than 6 months not necessarily will stay there. I don't know. That's not, I would probably let this one to answer somebody from physiology or epidemiology. It's not my area that I will be able to tell you more.
Thank you, Regina. Now we switch here to Saskatoon. Do you have any question? Please, I will ask you to come to the front if you don't mind to ask a question. So, ask the question.
Hi, I'm just wondering why you didn't consider a random effects model and chose to go with marginal effects.
That would have been another way to do it, but random effect is going to assume that any of these factors has to be not correlated with the other terms. And if that's the case, you get more efficient estimate, not necessarily consistent. Fixed effect is always give you consistent, but potentially inefficient estimate. But the coefficients are more reliable with fixed effect. And then if the assumptions are violated, then the results are not reliable with calculation.
The other comment would be...
I could have done it and then compare them and test them.
The other comment would be, it would be very interesting to look at it from a time to event analysis, giving you the opportunity to look at it over time. Yeah, that would be another direction to go, certainly.
I have one comment and one question. One comment is about the theory part. Can you move to the theory? The mic is here. Okay. The utility choice part. Utility of the medical care versus physical education.
I'm trying to.
Very good. This part, because in Canada, medical care is covered with public insurance.
Right.
So when we make choice, we don't take a dollar cost into account.
If it is just a dollar cost, yes, but there are other costs. If you want to stay in the hospital, that might be a long time, 10 days, and then consequence after that is going to be longer.
Right.
So there is opportunity cost of your time.
So I think so. If this is exactly why people have disincentive to exercise, because healthcare is covered by the government.
Okay.
It's like smoking, right? I don't care. I forgot lung cancer. Fine, government will cover it.
I'm not sure that will be easier to make that generalization, since even if you look at from the simple consumer theory point of view, it's not all about the prices, it's not about the constraint, it's also about the preferences. And then here there is more than the preferences. There is also health production effect that plays a role in the in this analysis. And I probably disagree with you about the point that you mentioned about healthcare being free and people really don't care about it, that's not totally free, because our time is also there.
Exactly.
I think the cost of time is going to be probably plays the biggest role here in this analysis, not the monetary price. Yes, monetary price is irrelevant in the Canadian context. But
Yeah.
if you are in the hospital, which suggests that time away from work and other activities is the opportunity cost.
So I just I commented rephrase this not dollar is all the inconvenience of using healthcare, all population level healthcare cost. It's not, I think the logic is not clear if it's dollar cost of healthcare.
Price, yeah, I mean, price could be monetary and non-monetary price, right? I mean, this is
all kinds of price, including.
It could be everything. And then if you want to monetize the non-monetary price, opportunity cost of people time, you can monetize it, and then you can express that in dollar term.
Right. Okay. My real question is about the log term.
Yeah.
Later, when you were mapping the impact of physical activity on hospital stay, saw this nonlinear effect, which is actually from the use of the transformation of log. Right?
If you look at this picture also suggests you that there is a nonlinearity there too.
Right, but the Z curve is like a sharp increase first, and it's
course.
from the use of the transformation of log.
Mm-hmm.
So how do you justify use a log? Because the dependent variable is a discrete variable. Hospital stays is not really very continuous, and energy intake is a kind of continuous. How do you justify use a log? Did you do any justification of transformation?
Transformation is just justified based on the, for instance, this picture. There's a nonlinear, effect there. So you have linear assumption wouldn't make any sense.
So why use a log? Well, not other nonlinear.
Okay, you suggest me some others, which is if I use in the future, I will go ahead and look at it if I do get anything significantly different. So log is quite, natural way to go. I mean, if you want to go away from linear assumption, right? You go for the nonlinear case. Logarithmic transformation is the easiest thing to do. If you want to think about the theory behind it, so if you have some sort of coplagos framework, you can imagine that linearizing that sort of framework is going to have you take the log, and then you might have some of those terms, perhaps exercise in log term on the right hand side. Depends on how you want to define it. Just fine, but yeah, I just go with the way that is usually traditionally used in the empirical literature. You could use other nonlinear form, but it should match with the data, and then log will actually match with this data.
Thank you. Let's switch to Regina. Regina, do you have any question over there?
Does anybody in the boardroom have any questions?
Nope, there are no questions from here, thank you.
Okay, if we don't have questions there, we come back to Saskatchewan. So, please, you have a question.
I have a very simple question, but maybe important. I was thinking about, did you think what other choices that male makes and that's responsible for the no association of male physical activity with the hospital stay? I was thinking maybe male makes other choices in the area of other healthcare utilization, like seeing a physician or something like that, that makes male less vulnerable to the utilization of the healthcare facilities. So did you think on this issue?
I see. Thank you.
Yeah.
And one thing that is in the model related to the provider, whether or not the individuals has family physicians. So if there is any sort of variation going on in terms of these individual has their family physician, potentially something can be captured there too. But I don't think that's the entire picture or entire story to your question. And if you look at those, some of this data for the data comparing those two groups by utilizations, sure where that table is. Right here. Yeah, you can see that, yes, you're right that the, males are using less of these services compared to female. And I do not know whether or not this is because of some sort of, healthcare service-related choices that the males will make compared to female. The data doesn't tell me, and then I won't be able to make any sort of generalization based on that. But if you would like to know whether or not this trend consistent with the other type of healthcare service utilization, which is available in data, that can be, also something that I can look at it. But I think picture is the same, that the males not necessarily higher utilizer of the other services. However, potential reason why we get that insignificance could be maybe explained by the bottom part of this panel, where the males are more active. And if in fact the marginal productivity of physical activity, impact of activity, decreases after you being extremely active, potentially females are already exploited all those potential positive effect of exercise, and there's nothing left to show. Might be one explanation, but I don't know. Just an explanation. Yes.
So thank you for the excellent presentation. My question is that, are you planning to do any cost analysis or to see how much it did save in dollars and how much it's going to save? Because I think it's very good to have the data from the Saskatchewan so you can convince the public policymakers and politicians to spend more on physical activity.
Good question, and very important question, and there's a lot of interest in seeing some dollars attached to these figures. And I try to be away from those approaches. A couple of reasons. One reason is this: what we observe here is the quantities, and the intensity of the care is not really known. Intensity means perhaps we do save some stays, but whether or not this stays, saving in these stays is going to translate into the comparable dollar values, which is across the board similar or not, is not known given the data. I could make some assumption where the assumption would be, okay, if this many of services or hospital stay can be saved before I come here, I was thinking that probably one of you will ask a question like that, which is not in the presentation, not in the paper, and I have no intention to use things because I cannot really back up these figures. When I do some overall estimate, I can see that this translates into about 1 million number, 1 million less hospital stays. And then if you have some sort of figure which will be good estimate for one hospital stay for this population groups, then I will be able to go from there to some dollar values. But what is that number? I mean, if I use average, it's a problematic value. One of the reasons is because we are talking about the decreasing the hospital stay. It's not to completely get rid of the hospitalization. So it's potentially you get lower marginal costs towards the end of your stay. You get the surgery in the first day, and then you use the hotel services after that. So additional costs after that, surgery is going to be quite small, and it's going to be for sure smaller than the average cost. So all we can get so far now is maybe average cost. But if I use our average cost and then translate this to the figure, it's going to overestimate the saving, which is not reliable. And would I be able to get this marginal costs? I'm not sure about that either, because we don't know what are the reasons that these people were in the hospital, and then there's a lot of treatment differences and then cost differences across different services. I do see. I mean, a lot of people are asking, and then last week there was someone from the BC. They were trying to write a paper to the health region, want to convince the health region, and then they were asking me to produce some numbers, because numbers are easy. If I tell them, $5 billion, it's easier than talking about, these numbers. People would like to see those numbers, but those numbers are not available based on this.
Do you have a question in Regina?
Go on, Regina.
I was a little confused about the use you had of the med level, and as well, I wondered what your cutoff for obesity was. I assume you used the BMI. At what level did you define obesity?
Excuse me, can you repeat the question, please?
At what level did you define obesity? I assume you used the BMI level?
Yes. Standard definition.
Standard definition. That doesn't mean much to you.
No, obesity is the, should I talk? Okay. Obesity is BMI 30 and yes, higher, yeah.
Okay. How did you define the MET levels? Do you have a MET level distribution in this population?
Excuse me, can you come closer to the microphone?
How did you define the MET levels? And did you have a distribution of MET levels in the population?
Thank you very much.
Thank you. Okay, the MET value is not something that I define. It comes, it's in the database. Perhaps you want to know what's in the database is the type of the activities and the duration of the activities. And the MET values for the corresponding activity is assumed by Statistics Canada. If it is walking, they assume that this is, corresponds to 1 hour of walking corresponds to 3 MET values. Of course, if you are walking extremely slow, it's going to be less than 3, and then extremely fast is going to be higher. You don't know that. But they seem that they are comfortable with the assumption. They cite some work from Canadian Fitness Association, and they seem comfortable with those assumptions. And then they say, there are potential that the people overestimate their level of activity, so they try to underestimate the MET values, try to overcome that. So I made an assumption that they know what they are doing. If not, then what can I say?
Do we have a final question or Regina? Here. Do you have any questions?
I just have a quick question about the methodology. Could your results have been skewed by the fact that the self-reported level of activity previously was just a marker for a degree of severity of any of the disease process? So take COP, for example, self-reported level of activity that was higher marks a less severe form of the diagnosis than the other. And so what you're dealing with is 2 populations of each of the diseases. And so what we found is that level of activity is a predictor of length of stay, because you're actually got 2 different populations each time you look at the disease. Does it understand what I'm saying? So that your self-reported level of activity, which in fact might be different between men and women, because there may be less veracity in one than the other. So those 2 things, and what you're really finding out is that that's the predictor of the thing, as opposed to saying activity makes a difference.
Good question. If this is a potential problem, which is there and changing over time, then there's no way you will be able to capture that. If the potential problem is individual specific and stay constant, then results false. That individual effects will capture that too. If in fact, for some reason, people reporting these bias and the bias stays the same over time. If not, then
I just think you're selecting a population by their report. So you've got 2 different populations, healthy and sick, of each diagnosis.
Yeah. I have to think about that. Yeah, let me think about that.
Well, I think we can have some space for a final question over here.
I think my question is also partly related to this question, especially with regard to the largely insignificant male, physical activity and male. And I suspect, in the regression, we have physical activity, but we also have other activities that determines how long one stays in the hospital. You realize that in controlling for those, there are other activities that probably in male become very difficult to control for. Now, I was reading a book and I realized that they said if a male has sex, he reduces the amount of physical activity that he gets. I mean, that is used in having sex. I mean, I just came across the book, so I was trying to look at whether it partly explains why we have a largely, insignificant results for male. So if he has sex, they said they disband that by one round. I mean, he releases and then that goes. That is equivalent to more than even our physical definition for the physical activity. And I'm trying to think whether is it possible to control for this parameter. And it is not possible. So if this part of activity, which increases man's activeness, is not controlled for, then we are always seeing that if you're already having this, any additional physical activity, any marginal physical activity doesn't add anything to man's stay in hospital. So the marginal activity of man's stay probably might have been defined by this other thing that other activity that man is doing, which is physical, but it's not measurable by distance or walking or something like that. I mean, that's the things I'm trying to see. How do we control for that? And probably that might be why we have male being largely insignificant. But I have the other two questions. One is the nature of physical activity. It doesn't matter. But we have averages in the thing. We have averages there. And then I was thinking, if, for example, per the physician definition, you need a consistent physical activity to get, to have this result of not staying in the hospital. So if, for example, that definition is 8 hours a month, and I decide to run 8 hours a day, instead of running 2 hours per week, so that I will have a consistent of 2 hours, 2 hours, 2 hours, and I decide to run 8 hours all in one day, does it have an effect on this outcome, for example? So the nature of a physical activity doesn't matter. And then the last one is talking about in terms of the status of the people, whether you are rich or you are poor. Where I'm coming from in the developing country, the data shows that you have the poor people who stay a lot in the hospital, but the data also shows that these are the people who do a lot of activity because they are living in a society or they are living in a place where the survival of the fittest matters. And if you look at how to survive, then you will definitely be involved in a lot of physical activity. So I don't know whether you are able to also look at these things, because these also give different dimension to how we capture, because that will be what I'm just saying now will be somehow there will be some contradiction, because you have in my case you have poor people being active, you have this, yet these active people are the people who are staying a lot in hospitals. You have rich people being less active because they spend a lot of time doing other things. For example, in the bank, they spend a lot of them, so they don't have a lot of time to do working, yet they don't stay a lot in the hospital. Now, data like this. How do you juxtapose this with that?
Okay, thank you. And there's a lot of questions. I'll give very short answer for each of them. Income is included, so that will take care of whatever that you mentioned at the end. And the first one, if people consider that as an activity, then there's a question after there's about 24 different type of activities asked to the participants, and then they say, okay, is there other activities that you do in your leisure time which will be physical activity? If the individual says yes, having sex is part of it, then it's included there. If they don't, then I have no idea, then it won't be there. And then if you are suggesting that the physical activity is underestimated for male, I don't know if that is the case, and then if that will be part of the leisure time physical activity. Another question.
The nature of physical activity.
Oh, nature of the physical activity. Yeah, the question asked in a way that respond to the question is number of time you do it in a week, and then type of the activity. Yeah. And whether or not you do this in I can look at it. I mean, I will be able to look at that, whether or not you do 8 hours a day and then never. But these are, if I look at it, I'm pretty much sure that this is not going to be a big proportion of the people who actually invest a lot in one day and then do nothing. That's probably reasonably distributed. But that's something in the data that I can look at it.
Thank you very much.
All right, thank you. Thank you for the questions and everything.
Thank you very much. Thank you.
Thank you so much for a very nice presentation.